Novel Oral Anticoagulants, also known as NOACs. 1. Other names: direct oral anticoagulant, DOACs, non-vitamin K-dependent oral anticoagulant, NOACs. 2. Either direct thrombin inhibitors such as dabigatran or anti-factor X like rivaroxaban, apixaban, edoxaban. 3. Contraindicated in pregnancy and lactation. 4. Contraindicated in mechanical prosthesis and mitral stenosis, mitral valve area 1.5 centimeters or less. 5. Contraindicated in the first 3 months after mitral valve repair or tricuspid valve repair. 6. Contraindicated in liver cirrhosis, child C. 7. The approved one in chronic kidney disease or dialysis is apixaban. 8. Antidote for dabigatran is idarucizumab. Antidote for anti-factor X, mainly rivaroxaban, is andexanet alpha. 9. When you switch from warfarin to NOACs, start NOACs when INR is 2.5 or less. 10. When switch from NOACs to warfarin, give both till INR reach 2 for 2 consecutive readings. 11. As a general rule, NOACs are stopped 2 days before surgery, except for dabigatran in patients with CKD, will need longer interval. 12. As a general rule, you can restore NOACs 3 days after surgery. 13. As a general rule, the risk of GIT bleeding with NOACs is more than warfarin except apixaban 5 mg twice or dabigatran 1 and 10 mg twice, which have a comparable GIT bleeding risk, similar to warfarin. 14. PTT can be prolonged with dabigatran, and dabigatran is the only one that can be cleared with dialysis in case of toxicity. 15. As a general rule, NOACs are at least as effective as warfarin, and they are more safe as regard bleeding risk. 16. The risk of hemorrhagic stroke or cerebral hemorrhage is low with all NOACs when compared to warfarin. 17. The only 2 NOACs that showed superiority over warfarin in stroke risk reduction are apixaban 5 mg twice and dabigatran 150 mg twice. Other NOACs have a comparable stroke risk reduction versus warfarin. Preventive measures of cognitive dysfunction in patients with AF include appropriate anticoagulation in patients with AF, and stroke risk factors should be applied for the prevention of cognitive dysfunction. Consider NOAC instead of VKA when using oral anticoagulation for the prevention of stroke in AF, which may have a beneficial effect on subsequent cognitive disorders. In patients with AF managed with long-term VKA, a high anticoagulation time in therapeutic range may be beneficial for optimal prevention of new-onset dementia. General health measures may reduce the concomitant risks of AF and stroke, with a putative benefit on cognitive function. Prevention of cognitive dysfunction in AF may include general measures proposed in vascular dementia or Alzheimer's disease. Cognitive assessment should be performed in AF patients where there is suspicion of cognitive impairment.